So good day, everyone. Thank you for joining another installment of the GPI webinar series. I am Genevieve Abdrani. I'm the Community of Practice Lead for GPI, and I have the honor of chairing this session. So before we get started, there's just a few housekeeping points that I want to note. This session will be recorded, so should you wish to not be captured, please keep your camera off. In addition, this is a webinar, and as such, you will remain unmuted, and also your camera will be turned off for the duration of the presentation. And then feel free to post any questions in the Q&A section, which you'll find at the bottom of your screen. And this will be addressed at the end of the talk. Also, feel free, if you are not able to post in the Q&A, just to pop it in the chat, and I'll keep an eye on that and just take it from there. So I'd like to now welcome our presenter today, and that is Rosalinda Tunowski, who is a co-investigator on the ParentApp Teams Tanzania project, where she leads the design, implementation, and evaluation of an engagement optimization trial. She's also a doctoral student in the Social Intervention and Policy Evaluation Unit at the University of Oxford. There's also more information on Rosalinda, and you'll find it on the website as well. But the title of the presentation today is Optimizing Engagement for the Digital Parenting Intervention in Tanzania. Rosalinda will have about 35 minutes to present, and we'll keep 15 minutes at the end for Q&A. So yeah, over to you, Rosalinda.
Thanks so much, Genevieve. I am just quickly going to pop my slides. Can you stop sharing so that I can?
Sure.
There we go. Oops. How does that look?
Perfect.
Okay, let me just see if I can move that over there. Okay. Good afternoon, everyone. I am really excited to be here today presenting the findings from our factorial trial, which took place in Tanzania between October last year and March this year. But before I begin, I wanted to just quickly emphasize that this is joint work, and although it forms the basis of my PhD, it wouldn't have been possible without the immense support and contributions from numerous people and partners, including my incredible supervisors, the entire UCT and Oxford research team, IDEMS and INIDEMS, and of course, NIMRI and ICS in Tanzania, who were our research and implementing partners. So before diving into the design and the results of the study, I wanted to quickly provide a little bit of background on parenting interventions in general, and a little bit more on digital parenting interventions, and then we'll go into the specifics of the project. So parenting interventions have proven to be effective across countries, contexts, and cultures, including low and middle income countries. And they've been shown to be successful in reducing child maltreatment, improving positive parenting practices, as well as addressing child behavioral and emotional issues. And these interventions can be universal, so they can be for all parents, or they can target specific subgroups, for example, foster care parents or children with disabilities. They can also be delivered in a group basis, so group format, or they can be delivered on an individual basis through various channels. So typically in low and middle income countries, parenting interventions are delivered at centers or in a group format, but they can also be delivered at individuals' homes. And most recently, they're being delivered digitally, although this is very, very rare in any low and middle income countries. And traditionally, parenting interventions were delivered by professional staff or paraprofessional staff, but with the rise of digital interventions, they are now being implemented in some contexts entirely self-guided. And what this means is that they do not rely on any form of human delivery to assist with implementation. So the focus of the presentation today is on the Parenting for Lifelong Health interventions, which is a suite of interventions which were originally delivered and developed as in-person interventions in South Africa. They have been tested and delivered in 29 countries, And most recently, we've been focusing on translating these in-person programs to digital formats. And this is really to address the global need for parenting support, as well as to prevent violence against children. So among the digital formats is Parent Chat, which is delivered via a WhatsApp group with trained facilitators. There's also Parent Text, which is a chatbot-based program for basic phones as well as smartphones, and this is delivered more on an individual basis to parents, and participants would ideally need access to internet for this. And then our main focus for this presentation is ParentApp. So the development and testing of ParentApp, or specifically ParentApp for teens, there's also a kids version being developed, but the teens version was developed first. So ParentApp for teens was led, so the development was led by the universities of Cape Town and Oxford, IDEMS, and the Tanzanian National Institute for Medical Research. And it's an open source, offline first mobile application based on the evidence-based Parenting for Lifelong Health for Teens program, but it also covers a few additional content areas, including parental mental health, which was added, online and offline sexual violence prevention, as well as bereavement resources, which were incorporated during the COVID-19 pandemic, but remain relevant outside of this context as well. So while ParentApp is based on the evidence-based in-person intervention, which we know is effective, ensuring positive outcomes with any digital intervention can be a real challenge because of low engagement rates. And this is a particular concern in low and middle income countries where access to digital technologies is much more limited. So, for example, looking at other digital interventions, we know that in other contexts, and specifically self-help interventions, only between 0.5 and 28.6% of participants actually end up completing the intervention. So many might start the intervention, but very few end up completing. And this means that they access a lot less content, and their chances for behavior change is also is much lower. So to address this engagement issue and challenge and big concern, we adopted the multi-phase optimization strategy framework, or the MOST framework, which has been used in multiple behavioral change contexts for interventions, and was originally developed by Professor Linda Collins and colleagues. There's a reference to that at the bottom of the screen. But this framework allows us to optimize interventions based on specific objectives. And this could be cost effectiveness. So we might want to optimize an intervention to be the most cost effective. Parenting outcomes might be our optimization objective. And in our case, it was parenting engagement. So the MOST framework consists of 3 phases: the preparation phase, the optimization phase, and the evaluation phase. And during the preparation phase, researchers will develop a conceptual model. They will identify a set of candidate factors or intervention components which they hope will help with optimization. And they'll identify the optimization objective, which in our case was optimizing for engagement. But again, it could be cost effectiveness, it could be a whole range of different things, or a combination of both. Researchers will then conduct some form of piloting, feasibility piloting, to assess what they've selected. And then finally, in the optimization phase, they will use what they've learned in the preparation phase and conduct a optimization trial. And this is typically some form of factorial trial, which is also what we did. And I'll go into more details about that in a moment. And then from the optimization trial, researchers will identify intervention components which meet the optimization objectives, and select these components which were most effective, and then they'll evaluate them formally in a randomized control trial. So this is exactly what we did. So based on the MOST framework, our preparation phase included firstly developing and adapting the intervention into a digital format. We then conducted user testing in 9 different low and middle income countries, mostly in Africa. followed by a feasibility pilot in South Africa with 107 caregivers. And this was a completely self-guided intervention where participants didn't receive any additional human support. And then we most recently conducted a very rigorous pre-post pilot in Tanzania with 102 caregiver teen dyads, where participants also received some form of human support. So we were testing what worked best. Participants were added to large WhatsApp groups to receive facilitator support. And we also tested one-on-one phone consultations, which is quite a normal strategy to provide some form of human support, specifically in the mental health literature. And then based on the results from the preparation phase, we did qualitative interviews, we had survey data. So based on these results, we conducted a cluster randomized factorial trial, which is the focus of this webinar. And this was really to determine the most engaging intervention components, and I'll go into what those are in a moment. And now we are currently in the phase of the evaluation where the optimized intervention is being evaluated in a larger cluster randomized trial in Tanzania as well. Okay, so moving on to study design and methods for the trial, we conducted a 2x2x2 cluster randomized factorial experiment. And this consisted of 3 factors, each with 2 levels, resulting in a total of 8 combinations of experimental conditions. The first factor was the guidance factor, and this we also called it the support factor, and this refers to the level of support participants received. And the self-guided level within that factor refers to participants only receiving the app and not receiving any form of additional human support. And the app did provide some forms of guidance, including push notifications and reminders, but no additional human support. And the other level was the guided level, where participants were allocated based on their cluster allocation to WhatsApp groups where trained facilitators who were trained by Clowns Without Borders South Africa would host a weekly live chat session where participants could ask any kind of questions. And they also received that peer-to-peer support. They could talk to fellow caregivers in their clusters and receive that sort of sense of community as well and advice. Moving on to the second factor, which we called the app design, and this really refers to the way in which participants accessed content. So in our qualitative and sort of in our feasibility piloting, we got a lot of feedback from participants that they wanted to access content in a more flexible manner. And the original version of the app, which we call the non-sequential time-bound app, was very much based on the in-person delivery format, where participants come to a group, they access they complete a session, usually on a weekly basis, and then take that information, go home, practice activities, and then come back and receive the following session. And this is how the app was originally structured, where new content or new session was released every 7 days. But feedback was that some participants wanted, they didn't want to wait as long, they wanted to access certain content and not other content that they thought wasn't relevant to them. So we tested these 2 designs, the non-sequential design, which was sort of the open version, and then the locked content design, which we called the sequential design. And then finally, there was the digital literacy support factor, which again, this was based on feedback from the piloting phases, where participants, even though they owned their own smartphones, really struggled with some sort of digital technological challenges. And so we thought delivering a very brief in-person digital literacy support training, which was quite general. It wasn't specific to the app itself, but more to navigating a smartphone, downloading new apps on Google Play, and using the internet as a tool for accessing knowledge and new information. So this was the idea behind why we wanted to include digital literacy. And so participants either received or did not receive the digital literacy training. And for more information and a more detailed overview of the study design and the rationale behind selecting these factors, you can refer to the study protocol. I've left the reference at the bottom of the slide. but I think somebody can also from the organizing committee will just post it in the chat as well. Okay, this is just to reiterate that even though there were all of these different combinations of conditions, all participants received ParentApp. So it wasn't like a classic randomized control trial where some parents received the intervention and others didn't. All parents received the app, and this included it was a 12-session program. It included welcome messages, parenting content and tips, practices, sort of practice exercises and activities, relaxation exercises, check-in messages, and supportive messages, as well as a positive parenting habit tracker where participants could log their positive habits that they learned throughout the intervention, and a parent library where participants could access additional resources, parenting tips, as well as referral information for their local communities in case they needed additional support. And then finally, to facilitate data synchronization with our online service so that we could access their engagement data, all participants were provided with a 1 gigabyte data bundle every month during the duration of the intervention. And even though the app itself was offline for the purposes of monitoring and evaluation, we still gave them data to access that so that they could sync their data. Okay, so moving on to trial objectives, we had quite a few objectives, but for the purposes of this presentation, I think we'll just cover the primary objectives as well as the first secondary objective. The primary objective was really to identify which of the selected factor levels contribute significantly to primary and secondary engagement outcomes, which I'll cover shortly. And one of our secondary objectives was to conduct exploratory analyses to examine whether there were any interaction effects between factors. And I'll go into the measures in a moment. I just wanted to go over what the procedure for participants looked like, especially going over the onboarding procedures, as this was sort of the only in-person component of the intervention. So initially, NIMRI, our research partners in Tanzania, conducted community sensitization and selected 16 clusters, which were from 3 different wards in Mwanza city, which were then randomized to the 8 experimental conditions. After the randomization, potential participants were invited to attend the in-person program. To attend the in-person, it was an introduction, wasn't a program, which we called the onboarding session. And participants were then screened for eligibility and then provided consent to participate if they wanted to. And in terms of eligibility criteria, caregivers had to be the age of 18 or older. They had to be the primary caregiver of at least one teen aged 10 to 17 years. And they had to stay in the same household as their teen for at least 4 nights per week in the last month. They also needed to be sufficiently literate, and this was really important because, of course, signing informed consent was important, but also to be able to navigate through the intervention without any guidance from a facilitator and to actually understand some of the content. Of course, the app was translated in Swahili, so it wasn't in English, but this was quite an important feature. And then finally, participants had to have some kind of regular access to a smartphone. So this didn't mean they had to own their own phone, and many of our participants didn't own their own phones. They brought phones from a spouse or a neighbor or a teenage child, but we just wanted them to have regular access to that phone so that they could actually engage in the intervention. Okay, so after participants were screened for eligibility and signed informed consent, they went through a group introduction, which was in person, where they got to explore a little bit of the sort of the app features very initially, and then they completed a baseline survey, which was integrated into the first session of the app. And the clusters who were allocated to receiving digital literacy training were also then provided with that brief training, which lasted, depending on group size, it lasted between 10 and 15 minutes. And sometimes if the groups were quite large and participants had a lot of questions, it would be 30 minutes, but that was quite rare. After the onboarding sessions, participants then completed the 12 sessions at their own pace. And those who were allocated to the WhatsApp groups would receive a weekly, would be added to WhatsApp group and would receive a weekly live chat session where they could ask additional questions and get additional support. And then at the end of the 12 sessions, participants also completed a inbuilt post-test survey, which was built into the very final session. Okay, so for this study, we had so many engagement variables to choose from, but we conceptualized engagement as a multi-phase process. And this was looking at engagement as sort of, initially participants would have to open up the app and start using it, just using the app in some form. The next level of engagement was considered accessing content, so reading the content. And the third phase, and the sort of most important phase, was to access and do the actual program activities and use the skills that were taught in the program. So our primary engagement measures were operationalized as the number of app opens, and this was sort of just using the app in some form. Then it was the number of sessions completed, and this was part of the sort of accessing and using the content. And then finally, the number of home practice activities initiated. And we then also had a few secondary outcomes, which were looking at the overall time spent on the app, the number of sessions started rather than completed, and then also the total number of positive parenting habits tracked throughout the intervention. So our engagement measures were digitally tracked throughout the intervention. And as I mentioned, participants would need to sync their data, which happened automatically as soon as they opened up the app and had access to data, to mobile data. That data would sync to our online server. We also collected caregiver demographic and behavioral measures, as I mentioned, through the baseline survey. And this was used to firstly inform us about the actual sample, and also used within as control variables. The demographic variables specifically were used as control variables in our outcome analyses, which I'll be reporting today. We also had a small amount of missing data in our baseline surveys, and this was handled using multiple imputation, using the mice algorithm in R. And once we had a complete data set, we also did a bit of post-processing where we grand mean centered all of our covariates within each imputed data set. So there were 10 imputed data sets, and we centered them within each one of those. And then for our primary analyses, we reported here, we conducted generalized linear mixed models, which accounted for the clustering of participants within their neighborhoods. And the independent variables used in the models were our three factors, so guidance, app design, and digital literacy. And our covariates, which were from our baseline surveys, were caregiver age and gender, food insecurity, financial stress, parenting stress, caregiver depression, positive parenting, harsh parenting. And then finally, we used Rubin's rules to aggregate the models across all of our 10 imputed data sets to create an aggregated result. So that's what I'll be reporting on today. Okay, let's move on to results. That's much more exciting. So just a brief overview of the participant timeline. We screened 866 participants for eligibility. Among these, 187 were found to be ineligible. This was mostly due to not actually owning a smartphone. Many participants arrived at the onboarding and information session and didn't have a smartphone, or had some sort of feature phone that looked like a smartphone but wasn't actually compatible with the app. We also had quite a number of participants, specifically older women, who weren't able to read or weren't sufficiently literate. And there were a few caregivers who also didn't live with their teens. Well, they did, but because it's very common for parents to send their children to boarding schools in Tanzania, especially at high school, participants lived with their teenagers did live with them, but at the time they were at boarding school and hadn't been living with them regularly. And we also had a few potential participants who weren't actually over the age of 18, and we couldn't include them in the study. So in total, we were able to enroll 679 participants, but of these, 65 of them didn't actually get the app installed on their phone. Again, this was mostly compatibility issues, where we thought, okay, their smartphone looked fine at the screening stage, but once we actually tried to install the app, there were numerous issues, including storage. There wasn't enough storage space. There were other technical issues. Inidims and idims have a greater idea of what that all looked like, but that was really the main challenge. Some phones also couldn't access the internet properly, so we couldn't actually install the app. And there were a few other issues where the phone looked like it was a smartphone, but it was actually quite a simple feature phone, and we couldn't install any additional apps on that phone. So those were some of the challenges we experienced at that stage. So we were finally left with a sample of 614 participants, and these were the ones that we analyzed, and this is the data we reported on. So let's take a look at some key characteristics of the sample. So caregivers had an average age of 36 years, which is quite relatively young, and about 33.39% of all of our caregivers were male, which was really encouraging. In our protocol, we had aimed for 20% of the sample to be male, so this was quite a lot higher than what we expected. And hopefully this also provides a lot of new research and new findings on how to engage male participants in a parenting intervention, in a digital parenting intervention specifically. About 33% of the sample reported experiencing food scarcity for at least 7 or more days in the past month, and about 32% of the sample reported that their teenager had experienced the loss of a primary caregiver in the last 3 years. And this was about 2 years after the COVID pandemic, so that sort of gives you a sense of what was going on at the time. So in terms of exposure and engagement in the intervention, impressively, we see that about 98% of the sample engaged with at least some content. The average completion rate for the entire intervention was around about 35% of the program content. So about 35% of the program content was completed by all participants. And in the table on the right, you can see a breakdown of completion rate by the sample. So about 38% of participants completed about at least 25% of the program. About 21% completed at least 50% of the program. Just over 13% completed at least 75% of the program, and only just over 7% completed 100% of the program. So that is all content sessions of the program. But encouragingly, if you look on the graph on the left-hand side, we can see that if we got participants to actually start a session, and that's the blue bar, they were very likely to complete it. So there's only a very small difference or dropout rate once participants had started a session. So the real challenge is how to get participants to start that session to begin with. Looking at a little bit more of engagement. So on average, participants visited the app just over 3 times, with each visit involving around 20 actions or pages viewed. So for each time they visited, they viewed about 20 pages. Overall, participants had an average number of actions or pages viewed, which was about 64 actions. And the median time spent on the app was about 46 minutes, which doesn't seem all that long. But if you look at retention days, so the number of days that participants were retained in the intervention, and this was calculated from the very first day of enrollment to the very last time participants synchronized their data to the online server. And the online server that data was only synchronized once participants actually accessed the app. So between day of enrollment and last synchronization, that was a median of 31 days. Okay, so now let's look at engagement for the different factor levels. Before I was just talking as sort of the overall sample. This is for different factor levels, and it's just a very brief overview to give you a sense of what our outcomes might look like. So for the guidance factor, participants in the WhatsApp groups had higher average program engagement compared to those in the self-guided condition. And this is also shown in the density plot. If you look at the one in the left-hand corner at the top, we can see that the area under the blue line is greater than the area under the red line, indicating higher completion rate for the WhatsApp groups. We see similar patterns for the app design factor. So participants in the non-sequential app design, this is the sort of the open access design where they could access any content as they choose, had higher completion rates compared to the sequential or time-bound app. And then finally, for digital literacy, we see that participants receiving digital literacy had slightly higher overall engagement compared to those who didn't receive digital literacy. Okay, so let's look at the factor effects for our primary outcomes. We observed that for the sequential app, so again, the sequential app was the time-bound app where participants had access to content on a weekly basis. For that, we can see that there was a significant increase in app launches, so the number of times participant reopened an app, but we see a significant decrease for that version of the app in sessions completed and home practice activities completed. So this could suggest that while the sequential app design effectively engaged participants initially, the non-sequential app design might have been quite a lot better in engaging participants in the content and the activities in the app. For the guidance factor, we see that the WhatsApp group support significantly increased the number of app launches and sessions completed, but we don't see any significant difference between WhatsApp and self-guided for the number of home practice activities initiated. So there was no significant difference there. And then for digital literacy, overall, we don't see any significant effects across all of our primary outcomes when looking at the sample who received the digital literacy factor. So receiving it or not receiving digital literacy training didn't seem to make a difference in the amount of engagement, the rate of engagement for participants. For our secondary outcomes, here we only see that the WhatsApp, so the guidance factor, but the WhatsApp support really seemed to be the strongest predictor of engagement for all of our secondary outcomes, for time spent on the app, for sessions started, as well as the positive parenting habits logged. And this is this is consistent for our secondary outcomes. So it seems like the WhatsApp condition was really quite a strong predictor of engagement for our outcomes. And then for our interaction effects, this was one of our secondary outcomes to see whether there were any interaction effects. And this would help us assess which combination of factor levels were most effective for improving engagement, which is quite important when you're thinking about implementation and intervention design for the RCT. Which ones do we really want to combine and put together in sort of newer iterations of the study? So here we see quite a strong pattern, and it's quite interesting. So in the previous slides, I mentioned that digital literacy did not show any significant effect, but we can also see that when we look at participants who received both the guidance, so both WhatsApp groups, as well as digital literacy, their engagement seemed to improve drastically. And we see that across all of our primary engagement outcomes. So for app launches, there was an increase in engagement. For sessions completed, there was an increase in engagement. And for home practice activities initiated, there was also an increase in engagement. For our secondary outcomes, in terms of interaction effects, we see the same pattern again, but not for all three of our outcomes, just for time spent on the app and sessions started. So it seems like the positive parenting habits logged, and you'll see it says parent points, that's sort of what we called it in the app, but it was the positive parenting habits logged, that didn't seem to be impacted by WhatsApp or digital literacy. Okay, so that actually brings me to the end of the results. I'd like to quickly go over some of the highlights and lessons learned before opening the floor for questions and feedback. So just to summarize, this is the first study to optimize engagement in a digital intervention or parenting intervention in a low and middle income country. Overall, we found that the average engagement rate seemed to be comparable to digital interventions in high-income countries, which is really, really encouraging. It was a little bit hard to really isolate how much better or how much worse we did, because of course there were so many different conditions, and most digital interventions do not use factorial designs to compare engagement at all. So they'll just report the overall engagement rates rather than looking at the sort of nuances that we looked at. We also observed that, similar to other digital intervention studies using human guidance, that engagement was significantly boosted by WhatsApp groups. And this is really encouraging because most digital interventions in high-income countries will use some form of human guidance, but it will be on an individual basis, which is not very scalable or very cost-effective. So we hope that something like a WhatsApp group support, where we can engage 50, 60 parents all at once, might be a really nice alternative and a slightly more scalable alternative in the context that we're interested in. Looking ahead, our next steps would involve figuring out how to enhance digital literacy support for our parents and caregivers, and also gaining a better understanding of what strategies would work best for specific subgroups, specifically looking at fathers, and understanding, what parts of the intervention worked for them, rather than looking at the results as a whole, which we did in the results presented here. And some lessons for future research. We found, I think this is something that was really important to us, that collaboration from the very beginning was really, really important. And that was not just collaboration in terms of designing the study and informing our partners how we were going to do it, but collaborating on the different piloting phases, discussing the results, because this is the first study in any low and middle income context. We really we couldn't rely all that much on previous literature. So discussing all of these results with our partners all the time and coming up with solutions that were very much geared towards delivery in Tanzania and other low and middle income contexts, specifically in sub-Saharan Africa, was really key. Planning for additional testing time was something that we could have benefited a lot more from initially. So planning to test the app, and with digital technologies and us not being necessarily, we weren't the programmers, we were the implementers and the researchers. There were lots of technical issues that sort of arose, and we needed to, there was a lot of sort of feedback to our development partners, and we used our research assistants and the facilitators in Tanzania to also test the app on a regular basis. So that feedback was really important, and allowing for that time is also really important, specifically also testing those survey items that were built into the app. In terms of implementation, planning for additional recruitment and onboarding time was really important. We conducted our study during the rainy season in Mwanza, and we encountered some delays due to this. So adding that additional recruitment time is really important, specifically when you're dealing with caregivers and families who are, who have economic activities and all of those things to do during the day, that expecting them to come to a half-day onboarding session is maybe not very reasonable or fair, because of course they lose out on their economic profits. And then finally, we encountered some challenges with our in-app survey data collection. This was mostly at post-test, so we had very few responses at our post-test. So figuring out how to collect data in this way, especially for scale up, is really important. Understanding what the barriers for data collection within the app or within any digital intervention where you aren't using research assistants to do that for you would be really valuable, I think, going forward. We got a lot of benefit from monitoring our engagement via live dashboards. And this was incredibly useful during the optimization phase, but I think during the evaluation phase now, the team has started using this even more to feedback and create that feedback loop to our facilitators who are facilitating the WhatsApp groups, and to our research partners in Tanzania to figure out, and to our development partners, maybe participants weren't using specific aspects of the app. Are there any bugs? What's going on? So I think having that live feedback loop is really important. And then finally, planning for additional analysis time between the optimization phase and the evaluation phase is something that I think we could have benefited more from, and just something that is always important to think about when you implement something like this. Okay, that leads me to the end of the presentation. Thank you so much for being here and listening, and a massive thank you to our partners and to our funders, and of course to the parents who participated in the study and made all of this possible. Yeah, thank you.
Thanks so much, Rosalinda. Very informative, and I think you covered quite a bit in the short time. And just to have a look at the Q&A, so there was a question that somebody posted directly to me, and I've reshared it on the chat. I think they might have been struggling to see the Q&A box. And it was around the intervention. So was the intervention evidence-based developed as an in-person before and then redesigned afterwards? I'll give you that question for you to answer, and then I'll answer the next one.
Yes, it was. So the intervention was based on the evidence-based PLH, or Parenting for Lifelong Health for Teens intervention, which was tested in randomized control trials in South Africa and has been sort of scaled up and rolled out across a very wide range of different countries, and adapted. So it had never been tested as an evidence-based intervention in Tanzania, but there was a very large scale up of the in-person intervention in Tanzania, I think with almost 40,000 participants, which was delivered. And so we adapted the content for digital format, but the content itself, which is evidence-based, was exactly the same as the in-person intervention.
Thanks, Rosalinda. The next question, did the non-sequential design not affect the content delivery? So that is, if some sessions didn't need to be done after others.
Yes, it did, and that was a big fear for us, because there was a lot of thought that had gone behind the order of the sessions. We wanted participants to access certain content first before they go ahead and do maybe harsh discipline sort of content, or sort of the heavier topics that the program includes. But the way that it was laid out was that we still encouraged participants to do it in that order, but they could access the other content. So even there was still an order in which the sessions were presented to participants. The two apps also differed slightly visually. So based on the order and sort of based on how we wanted to present that content. So it wasn't, even though the content was identical, the two apps actually looked quite different. I don't know if that answers your question, but you can pop me a message if you want to discuss it a bit more. And the trial protocol also has a bit more information on what the two apps looked like.
Thanks, Rosalinda. Next, Ramaya is asking, did the live WhatsApp session make a big contribution on the role of WhatsApp group? And do you think not having the live session will produce a different outcome?
This is a really, really, really good question. And I think something we struggled with a little bit. So in the optimization trial, we found that even though WhatsApp hugely contributed to engagement, very few participants actually actively engaged in the live chat session. So I think, the WhatsApp groups were about 40 parents per group. We had 2 facilitators in each group. So we had a lead facilitator and a co-facilitator, and one male and one female facilitator in each group, which we thought was quite important because we had a lot of male caregivers. But on average, I think only about 3 or 4 participants actually, out of those 40, actively engaged in the live chat sessions. All the other engagement seemed to be sort of peer-to-peer interactions or asking facilitators for sort of questions outside of that live chat. So I think looking at ways of, if we think, okay, live chat might be a little bit too resource intensive, looking at alternatives might be a very feasible thing to do. I think engagement is looking a lot higher in the randomized trial now. I don't want to sort of give away any results for there because we don't have any final results. It's still ongoing. But I think so for us, we had a lot of learning to do of sort of how to engage those participants, and especially because mobile data seemed to be an issue for participants. They would receive their monthly mobile data, but it would be depleted very quickly. So attending a live chat where there's sometimes, a video call wouldn't have been, a lot of participants didn't want to do that because they didn't actually have the data to do that, or they didn't have the time. So they would rather just catch up on the messages afterwards. I don't know if that answers your question, but I think it's a really good question to think about for implementers in general. How do we want to implement this? And I think our teams, the parent text trial, which is going to start in South Africa shortly, has also sort of gone above and beyond what we did and are thinking about how to do that implementation slightly differently.
Mm. And then a kind of a follow-up, but also similar, like around the WhatsApp group, and it was something I was thinking about as well. So what kinds of interaction was done via WhatsApp? So was it Q&A? You spoke a bit about a live video session. Not sure if you actually ran one, or was there personnel that was supporting the people, so participants, if it was an interaction type thing? Was it text or video? Yeah,
it was,
some more insight.
That's a really good question. It was mostly text. Facilitators could choose how they wanted to communicate with their participants. So there were some voice notes, a lot of sort of voice audio recordings. The facilitators who were trained for this specific to deliver the WhatsApp groups, they mostly they set ground rules with participants at the start and sort of said this is when they'll be available. They won't always be responding to messages 24/7, that it's completely okay for participants to chat amongst each other, but yeah, the medium of sort of referring information was mostly audio recordings and text, but the facilitators didn't actually deliver any content, if that makes sense. So they reminded participants to use the actual app, and I think they did a bit of the review sessions and asked if there were any questions after having completed the home practice activities. But it more served as a reminder rather than as a actual content delivery channel.
Sure. Then Leanne has a question as well. Was data on the program effects on parenting behaviors collected? And is this anticipated to be associated with parent engagement with that?
Very good question. So yes, it was collected, but as I mentioned, our post-test data was, response rates were really poor. So we had maybe 10% or I think maybe 17% of the sample actually responded to some of the post-test questions, and not all of them, because of course those were also voluntary and you could just skip through them if you felt uncomfortable responding to a question. So we do not have a full sample, a full data set for that. We'll definitely analyze that data. And yes, it is expected that with higher engagement comes better outcomes as well. So that was one of the sort of big research questions I had in my PhD. It's something I can't really respond to very rigorously or analyze very rigorously, but with the data we do have, it would be really interesting first to look at why did the participants who responded, are they different to the rest of the group? What sort of motivated them to respond? And then also, why did participants who completed the final session not complete the survey? And are there ways of encouraging that completion through phone calls or some kind of incentive, because they didn't receive any sort of incentive to do that?
Sure. And then how was the parenting app launched on WhatsApp? This is another question.
Oh, okay. So it wasn't launched on, I might be misinterpreting the question, but the app was a standalone app that was installed from the Google Play Store. And on WhatsApp, we made sure that participants had WhatsApp, and those participants would then receive support and encouragement to use the app, which was on their smartphone. So the app wasn't on WhatsApp, but you might also be talking about Parent Chat, which is a WhatsApp-based delivery of the Parenting for Lifelong Health programs. And there, the content was actually delivered through audio and visual content, so through messages and photos and pictures and that sort of stuff. So I'm not sure if I understand the question correctly, but if you are talking about ParentApp, it wasn't part of WhatsApp. It was they're two separate apps that participants were using essentially.
Thank you. Still a few more questions. So, will this data allow you to determine minimum engagement dosages required to drive the desired outcomes and impact? For example, in different contexts, we may see impact and outcomes plateau with little improvement in outcomes between those who have engaged between 75 to 100% of the content, or are there plans to look at this in the future?
Yeah, definitely. So that that would be, you can determine that through case analysis, causal effect analysis, where you can look at the dosage that participants got and compare that to how much their outcomes increase. And because our outcome data isn't very strong, it might be challenging for this specific study, but for our evaluation study in the randomized trial that's taking place now, we are collecting engagement data and we're collecting outcomes data, and doing that sort of rigorous analysis there will be really important. We can, though, use this data as sort of a baseline for retention and engagement, or what to expect in slightly more real-world settings that were a little less controlled, or sort of, because participants owned their own phones, and it was sort of in that context, we could anticipate a sort of minimum retention, maybe not how it links to outcomes, but definitely what we could expect from engagement with that sort of sample.
Sure. This was a question, I think this person said that the internet was a bit unstable, so they might have missed some of this information in your presentation, but they wanted to know what were the age ranges of the caregivers, and the ages, if the ages were similar for male and female, and also the age factor at all in any of the results. Did it have an impact?
Really, really great question. So we had a number of very young caregivers. We had some 18 and 19-year-olds who were mostly the brothers or uncles of a teenager and were the primary caregiver. The oldest caregivers were, I think the oldest one we had was 75 years. So I mentioned that the average was, I think, 36 years, but our oldest was 75 and our youngest was 18. In terms of how age affected engagement, it actually did. I'll sneak peek into that, is that it seemed like digital literacy, even though it wasn't an important factor for overall engagement, participants who were older, so our older caregivers, actually digital literacy was effective for them. Whereas our younger caregivers, who presumably already, they had their own phones, they were more used to using technology, probably didn't need digital literacy. So that's one of those like tailoring aspects that I spoke about, where some of that content or some of those delivery components might not be appropriate for all caregivers. So that's a really great question, and looking at how age impacts outcomes and engagement is really important. I can't answer how fathers engaged based on age compared to mothers, but I will look at that in analyses. And hopefully do another webinar to present a little bit more about that.
Thanks. A question from Bernice. Were questions on participant home practice collected via self-reports and embedded in the program? What sort of questions were asked? I'm thinking of questions where, if they were on frequency of practice, or whether they participated or not, or practice, or not.
It's a really great question. So for this version of the app, the way we collected the home practice engagement was actually not via self-report. It was whether they there was, at the end, there was a question on how it went, which is kind of self-report, but then also whether they clicked on the sort of instructions for the home practice activity. So there's a section in the app where it's like, have they started the home practice activity? And then afterwards, how did you find it went? I think for the RCT, it's a bit more, there's a bit more self-report involved, where it goes into like, what were the challenges, what went well, and that's a bit more sort of self-report, but we didn't want it to be too explicit and feel like a test, or like they'd done something bad if they weren't able to do it. So it was a very sort of very simple way of rather trying to provide support and encouragement rather than, reminding them that they didn't do it or they didn't do it well enough. So it wasn't, I don't know if that answers your question.
Thanks, Rosalinda. We have a few minutes left on the call, but there's still a few questions. And if it's okay with Rosalinda, we'll go over time, and whoever can stay on the call could just get some feedback on the questions that they've posed. The next question, and I do see that there's a hand up. I just want to get to the questions in the chat. Did you consider digital literacy in the way parents were recruited? I know you touched a bit on this, because it's one of the things, it's one thing to have a smartphone, but it's another thing to understand how to use it or to know how to use it. And then as part of this question, also, how about parents in rural areas? Were they involved in any way?
That's a really great question. So I actually start at the end of that question. So our clusters were sort of peri-urban informal settlements in Mwanza. Some of them were what I would consider, sort of from a South African context, I would consider that a bit more rural than, I wouldn't really consider it urban, and definitely very sort of minimal resources in terms of running water and electricity and those sort of things. Our pilot took place in both Mwanza and Shinyanga, which is a province which was completely rural. So that was where we actually provided participants in those contexts with smartphones, very simple smartphones. And they had almost no experience using a phone, let alone an app. And they in the pilot received a lot more intensive support. What we were trying to test was a very sort of quick method of digital literacy support for participants who already had some kind of exposure to smartphones. But we did find that a lot of, especially older caregivers who came with their spouse, with their husband's phones, for example, they'd never actually used a smartphone before or used WhatsApp. So that was a barrier to engagement that we hadn't really anticipated and hadn't allocated a lot of resources or time to assisting those caregivers. Because we were giving them very specific conditions, we didn't want to give some parents a lot more support than others. So we standardized it across those experimental conditions. But certainly in the RCT now, we are sort of tailoring that digital literacy based on each caregiver's needs. And some don't need it at all and others do.
Thanks, Rosalinda. From Brian, do you see a potential connection between the relatively high participant rate of male caregivers and the digital technology focus of the intervention?
That's a really great question, especially because we had a lot of our young caregivers were male caregivers. In our qualitative feedback, so we conducted qualitative focus groups after the study had completed, we got some very interesting results, and I'm sorry that we weren't able to present those today. It's really fascinating and really informative that some of the fathers said that they struggled with so I think this is some context in Tanzania, that men generally didn't have very expensive smartphones. This is a generalization, of course, but from the qualitative feedback, that's sort of how they phrased it. Whereas women actually did have slightly more expensive, smarter looking smartphones, especially the younger ones. So men had complained, the fathers complained that their phones, like the screen was really small, the space, they didn't have a lot of space on their phones, and that was actually a massive barrier to participating. So because their phones were older, and they didn't have a newer phone, they didn't engage as much. But I think if we look at sort of the age factor and how males engaged based on age, I'm sure that we'll find that the younger male caregivers probably engaged. Well, actually, there might be a trade-off whether that engagement, because there was a bit of an incentive to participate at the start, they received a small amount of cash to actually attend the session. That was a little bit of an incentive, and that cash was really only provided to provide transport to and from the session. But then also that regular data, participants were incentivized to attend or to sign up to the intervention, but engagement might have also been, they weren't all that interested. So screening was really important, and the way we did recruitment is definitely something that we can improve on in the future.
Thank you. I'm going to switch over to the Q&A side now. That was questions from the chat. One of the questions was, thanks for the good work. As we are planning to follow in your footsteps or your steps, we were wondering what experience you could share about launching ParentApp through WhatsApp. I know you touched a bit on this.
Launching ParentApp through, so I'm not sure I understand that question properly, and whoever wrote it might want to elaborate on that. So ParentApp wasn't really launched through WhatsApp. Because it was two separate apps. It was ParentApp, and then WhatsApp is its own app. But I think if you're asking how did we
possibly launch it?
Yeah, so we did an in-person onboarding. So that meant that we had research assistants who assisted parents with downloading. So participants would first need to install the app on their, or download the app on their phone and then install it. And then it would be on their phone. And then they'd also need to have WhatsApp to engage in those WhatsApp groups. I think, there might be examples of how to maybe do that recruitment and onboarding online. I'm sure that's possible, especially with sort of more technologically confident parents. I'm sure that's possible. But launching it the way we did with that in-person session was really important, especially because at the time, I believe, so because there were those two versions of the app, our research assistants needed to make very sure that participants were receiving the right version of the app based on their cluster allocation. So we needed to make sure once we opened up the app that we locked it in like the sequential or the non-sequential design, so they couldn't go back and forth and to experience the two different designs. But essentially launching it in person is the way we did it. It's open access to anyone if you want to view the app yourselves. It's on the Google Play Store, so you can find it there. And so parents maybe in a slightly not in a research setting can also access that content if they want now. So that's another way of launching it, I guess.
Follow-up question as well. How were you able to tell that the session was completed?
So the way we measured that was that parents had clicked through or had gone from the first page on the app to the final page. So that's how we measured it. So they would have needed, and then I think at the very end of each session, there was a finish button. And once they'd clicked the finish to take them to the next session, that's how we measured it.
A question around the findings that were very interesting, that 33% of male caregivers were involved. Who, in terms of engagement, was more involved, so male or female?
It's a good question. Females on average were slightly more engaged, but I think if we look again at age and a few other factors, it might give us a slightly different picture. We see that, yeah, and it also depends on the outcome, the engagement outcome variable. So I can't answer that exactly because I haven't done those analyses in full, but I do. There's one slide where I showed that average program completion was slightly higher for females, but if we look at average time spent on the app, for example, there was no significant difference. Males and females spent the same amount of time on the app. And if we look at the retention days, so how long males and females engaged with the intervention in terms of days, there was also no significant difference. And that was done, I looked at a survival analysis for that, and there was no significant difference between genders.
Thank you, Rosalinda. There's just a few more questions, and I think we'll just take what's left over here. So the next one was, this person, I think they might have joined a bit late, but they're saying, or they might have just missed something. What was the purpose of the app? If you can just...
So the purpose of the app ultimately was to prevent violence against children. So that is the main objective for Parenting for Lifelong Health programs. There were, I should have maybe provided a slide on the content itself. There was some there was content on family budgeting and creating a safe environment. There was problem solving and using non-harsh discipline strategies with teenagers. So, but really it was to create a positive parent-child relationship, and also to prevent severe forms of corporal punishment and violence towards children, both emotionally and physically. And then there was content on sexual violence prevention, not specifically for parents themselves, but within the community. So there are a range of outcomes that we're very interested in, but violence against children is really the main one.
And then, do you have any data on father-mother dynamics during the program? So if one parent participated in would that parent then share the information?
Yes, we do. We have that via qualitative data. So how parents reported how they ended up using the app. And this is both from the pilot and our optimization study and the randomized control trial, where often fathers would sort of give permission to their wives to attend. So it would be the males, it would be the father's phone, the mother would be participating in the sort of engaging in the content, and then sharing that content with the family. But that wasn't necessarily how it always went. There were some fathers who really enjoyed teaching their families. So they would go through the content and then they would sit down and actually teach what they learned to the wives as well. I think in the pilot, we found that it was really the adolescents, because we did it in a rural setting there, the adolescents were very involved in encouraging parents to engage in the app. So they were the ones actually reading the content because of literacy issues. They were the ones that were actually doing a lot of the engagement. So it was a lot more mixed than what we expected. We were actually really excited to see that adolescents were so engaged in the intervention.
Sure. Thank you. The last question. Do you think that educating participants who own smartphones other than regular access would have changed engagement proportions?
So the pilot, we provided phones, and our engagement was higher, but we also provided a lot more. We provided a lot of human support there. And for our setting where participants had smartphones, I think it will be quite different and very interesting to see if it's participants' own phone and they regularly use that phone, or if it's borrowed. So we had a lot of parents who came with their neighbor's phone, or somebody came with a work phone. It wasn't their own phone, and they wanted the app so much that they came and put it on their work phone. They weren't actually allowed to. They came back and ended up buying themselves a smartphone, a very cheap smartphone, removed the app from their work phone and added it onto their new phone because they really wanted to participate. So very interesting dynamics. But I think it does matter if it's their own phone, or if it's a borrowed phone, or if it's a provided phone. So I know in high-income countries, parenting interventions often do provide, and it's not always smartphones, it's sometimes tablets, it's sometimes computers, depending on the type of intervention, but I think it does really change the engagement.
Thanks so much, Rosalinda. We've gone over by 8 minutes, but you've actually managed to answer all of the questions. Let me just make sure I haven't missed anything. No, I haven't. Could I say that if people want more information, they could reach out to you?
Absolutely, yes.
And Rosalinda's
and
information.
the ParentApp team in general, I think we are a very big and vibrant team, both based at the University of Cape Town and University of Oxford, and NIMRI in Tanzania. So there are lots of experts on this. And so if you're interested in sort of the different versions of the piloting or the randomized control trial that's taking place now, please get in touch. We're happy to answer questions or have a call.
Thanks so much, Rosalinda. And thanks to everyone for joining today, and everyone that actually stayed on the additional minutes just to get the final Q&A. Take care.